Thank you very much. And I guess first, before talking about some bronchoalveolar, sampling the airways, bronchoalveolar lavage, I'm just going to take a minute to just say a couple of other things that I think are really important. And I guess first of all, I really appreciate the good organization and preparation for this conference and being invited here to participate. And I really enjoyed Maastricht and seeing a new place and meeting a lot of people who we've known and seen before. So it's a great pleasure. But coming to one of these meetings, and now this is obviously the second joint WASOG-BAL, and I think it's a natural confluence of people that have very similar interests. It makes you think back about people who are not here, and the Jared James and people like that have been so prominent. Miss Om Sharma and some people who we usually see. And then I was just intrigued by the Wegener's granulomatosis talk and remember seeing him, Dr. Wegener, about 20 years ago in Milan, I think was where it was, and being really so surprised about what motivated him. And really, as an example, maybe there are not so many here who are early on in the investigative part of their careers, but realizing he, like other people in pulmonary medicine, Laennec being one, did things when they were students in training, and it sort of prepared them the whole way. And Dr. Wegener told me that he was really a medical student, a third-year medical student, when he first saw the pathology and some of the things that contributed to his interest in granulomatous disease, et cetera. So there's a lot of history, I think, that draws us together. The second thing is that this has been an incredible 2.5 days or a little bit more in terms of the breadth of topics that have been discussed and what we've been exposed to. And like everybody, I guess, as a physician, you worry about your continuing medical education credits and are you going to get enough points to keep your license active. And so we plan to go to review courses and participate in grand rounds every week at our medical centers and so forth. By golly, it's all been right here in 2.5 days. With the exception of not hearing much about asthma or COPD, which you would expect. But I think I counted from the program that there have been 15 different pulmonary topics ranging from granulomatous to pulmonary hypertension to everything that you can express. So it's been a great review course. But coupled with that have been 100 posters out there of research that is ongoing work that you can evaluate. And then other parts of the meeting, such as we had this morning, an attempt to really look at developing some guidelines for clinical trials, sarcoidosis. Some of that was brought out with idiopathic pulmonary fibrosis items the day before, which really will help significantly, I think, improve the quality of research and improve funding aspects and so forth that might make some of the research in sarcoid more competitive and so forth, that you have better structured clinical trials. So that all coupled together, I guess I'm really pleased to get that little certificate that you all get that will really help with making sure that we keep our, CME credits and so forth. So that's important. But my assignment is a perspective of BAL, and I'll address that because Mark's going to talk more about sarcoid in his comments in just a few minutes. But first, before speaking about BAL, I realize that from my perspective, this is an anniversary in a way. It's not June 2000, it's not exactly this month, but it's later in the year that it was in 1971 when I was at the National Institutes of Health in Bethesda that we got access to the first fiber optic bronchoscope that we had. Dr. Akita, as you remember, who developed the fiber optic bronchoscope in the late 60s, he came to the States and brought two. One he took to Miami, and Adam Warner and colleagues worked on that. The other came to the National Naval Medical Center in Bethesda, which is just across the street from the NIH, and they used it for a while. But then my colleague, Harold Newball, who was involved with a lot of the bronchoscopy things that we were doing, because we, like everybody else, were sampling the lungs. I mean, people in medicine have been looking at secretions, phlegm, and secretions in the lungs for at least 2,500 years. It's been used to assess things related to respiratory disease, phlegm, expectoration, sputum, etc. People have been washing out the lungs for 100 years with rigid bronchoscopes and so forth. But it's only been in the last 40 or so years that we've kind of coupled that with the very important diagnostic tool of the fiber optic bronchoscope and transbronchial biopsies and all that sort of thing that I think is really brought pulmonary medicine diagnostically and research-wise really to the fore. So it's with that feeling of some perspective that I'll really talk about the BAL and what we've heard in this conference. First of all, somebody walked up to me after and they said, there's not very much about BAL in this conference. I said, I'm not so sure about that. Let's see. Anyway, in looking at the 100 posters here, 25 of the 100 posters have had aspects of BAL or respiratory sampling in them. And I frankly have been through all of those posters, and that's really going to be the essence of what I want to summarize quickly. But before doing that, I wanted to pick out one thing very specifically about BAL. And Dr. Mayer's here in the audience, and it was the Meet the Professor. How many of y'all went to Meet the Professor? There weren't a whole lot of us here. And in the program it just said Meet the Professor. But do you know what the Meet the Professor was all about? It was about the developing guidelines and so forth that ATS and European Respiratory Society and so forth are putting together, really showing just the way they've done for IPF treatment and so forth, trying to put together in an objective way the evidence-based and how all these things will be used. And it's fascinating. And Keith said that it's in the final deliberation, I guess, by the executive committee or the editorial committee of probably the Blue Journal from the ATS, and will probably be publicized. But that's something that's been, as you indicated to me, that's really something that's been worked on now since the early 2000s, 2003, 2004. So something that's going to have a huge impact on how we decide to do things has taken a long time to get consensus and get developed. Well, let me sort of start with BAL. And the other thing it lets me do is sort of pick up from the 11th BAL and WASOG meeting that was held in Athens 3 years ago, because I had the same position then, is to sort of critique the program. And that was published in the journal and so forth. And in that sort of overview, there were three things that I sort of made projections in that I wondered how we would address those in this meeting that we're having right now. And the three things were about continued revelation of new findings in the airways that would be helpful in research or clinical use, etc. The second was what might be the discussion and concern about how effectively we in pulmonary, I'll say generally, pediatric as well as adult, critical care, etc., are really attracting the up-and-coming next generation, our clinical scientific colleagues who will continue on. How are we attracting them into the field of research? And I think it's no issue that, at least in the States, elsewhere, that the pipeline is not filled as much as it should. This is a very propitious time to be in research with all the omics and all the technologies available, and we are really not attracting enough people into the research field. The third thing would be sort of how are we unraveling the things that we still don't know about the human respiratory tract? And that really sprung from a workshop that we sponsored at the NIH in which we got prominent pathologists to get together and say, because I mean there are 44 or so many cell types in the lung, and at best guess, and the pathologist said, we know about half of those cells. We know what 20 or so of those cells are doing well, but the other half we're pretty ignorant about in terms of separating these cells out, looking for their function, being able to use surface markers that we've got, monoclonal antibodies, so that we can separate these cells out, perpetuate them in long-term culture, and really study. So in terms of what the future offers, we've got a lot of fairly basic things to do. So let me stop with that, but start with just a brief overview of the new science that we've been hearing, and this will be brief. Revelations about new things that we found in bronchoalveolar lavage. As I said, 25 of the 100 posters out there had some component of lavage as contributing to the results. And I really wasn't going to talk about comments about lavage that were made in these plenary sessions when people spoke about lavage, because that's usually published work and people know about it. And it was very interesting just in the last group to hear people talking about the use of lavage to help with hemorrhage in the lung and some of these things that we have pretty good use of this technology for. So in looking at these 25 posters, I tried to go through and separate things that would be related to sort of a comprehensive assessment, how sampling the airways is improving the overall concept that we have about the immunopathogenesis of some diseases. Secondly, I was interested in things that look like special cellular activity, something that sort of surprised me that I really wasn't aware of. Looking then for things that seem to be new mechanisms, new things that we are uncovering about some of these diseases, new methods, and I'll define methods because we're talking about bronchial lavage, and I guess I've for a long time have had the thought that we're sampling the respiratory tract surface, and bronchial lavage is but one technique for that. And we can use nasal washings, we can use selective lavage, but increasingly the new technologies, the exhaled breath condensates, nitric oxide, some of these more or less non-invasive things that lend themselves to use because they might be done more frequently. They allow themselves for monitoring patients less invasively. And the other thing, particularly, if we can see how much of the upper respiratory tract really reflects the lower respiratory tract, we might have a much less invasive way to sample the surface of the airways, et cetera. And finally, were there any animal models that looked important? Because after all, there's so many diseases that we've talked about, and except for the particulates and silica and some of these diseases, we really don't know the etiology of most of the diseases we're talking about. So therefore, it's not surprising that a lot of therapy that we've heard about is really empirical. We hope it works, but really until you kind of have a cause effect and know the mechanisms of disease, et cetera, it's very hard to be very specific about some of the therapy and so forth. So let me iterate a few of those. I think, and rather than name the people and the location, I've used the book, and there's a little, can be an A1, A2, there's a number, and I'll just refer to that. So in terms of some of the revelations that come out in the lavage, first of all, I would point to G1, the abstract G1. And this seemed to sort of represent more of a comprehensive assessment that is being done. And this was in sarcoid patients, and it really was analyzing the proportions of CD4, CD8 cell T cells in sarcoid, really now looking at three compartments: the blood, the lavage, and then sampling mediastinal lung lymphoid tissue. And so looking, and the very interesting thing is that the proportions of the CD4, CD8 are different in each of those things, which really kind of gives you some feeling about how things might really be monitored in the body or really involved. And I think that that might be important. The second area would be some special cellular activity. And this was one of the oral presentations, 04, oral presentation 4. And it was talking about sarcoid BAL cells. And really for the first time it was including the percentage and the effect of dendritic cells in the airways and that's so interesting. And back in Washington, I have occasionally see a Dr. Henry Yeager early on in sarcoid, but I think described to me the most fascinating thing in all of cellular immunology, the so-called alveolar cell rosette, was an alveolar macrophage with naive T cells around it, and you just kind of wondered what the T cells were picking up for the surface of the macrophage. Well, as it turns out, and he knows it too, these are dendritic cells. So the whole antigen processing and Th1 process and all that goes is really more driven by dendritic cells. And so I really didn't hear too much about dendritic cells here, but they're important, and I hope we'll see more of that in the future. Other kinds of things, I won't, B1 was talking, abstract was talking about really some effects of messenger RNA impact on IL-23 receptors, etc. F7, we don't see cryptogenic organizing pneumonia too often, but it is interesting how when it relapses, it's a very characteristic relapse with the cellular changes that we're kind of used to seeing, increased lymphs, increased polys, etc. This I thought was one of the most fascinating things, and this was the G11, and this was in smokers with sarcoidosis, and they were looking at one of the FAS components in BAL, and it really seemed that when the FAS levels were decreased, that then the degree of apoptosis was increased. And it helped explain for me, which we, I think, empirically have kind of known, that people who have sarcoidosis, sometimes who are cigarette smokers, actually have less severe disease and seem to do better. Well, there might be an explanation for that. At least this is the first time I heard a logical reason for that. Amongst new mechanisms in sarcoid, this was oral 3 presentation in sarcoid. I guess I've been interested in the PAR, alpha, gamma, and the things that regulate cell and probably regulate the granulomatous response, but I guess it was a new finding for me that the PAR alpha is actually decreased in relation to the CD4 cells in sarcoid. It might give some indication of activity, how we express it. And finally, in this new mechanisms, this was G2. I mean, we know we've got a lot of CD4 cells, CD8 cells, their relationship and so forth, but it was fascinating to have somebody point out what happens if CD8 cells become exhausted. And the fact was that with exhaustion, which was really related to one of the receptors, PD1, that if in fact the cells got exhausted, then they just didn't function as well, and these people might tend to have more infection or more complications from sarcoid. It seemed like to me this might be a new thing to monitor, plus it might be a thing to focus on in terms of new therapy, which I thought was exciting. Finally, in new methods, well, new methods to me really are things that are not bronchial lavage, but other ways of really evaluating the respiratory tract. Now, of course, if we were here talking about asthma or allergic rhinitis and a lot of allergic diseases, there'd be a lot more, I think, about exhale breath condensate and nitric oxide and some of these kinds of things, but not too much addressed in some of our research here. So both of these, G4 was assessing granulomatous factors and exhale breath condensate, which they didn't find significant things, but they were at least trying to analyze it in a non-invasive, less invasive way. H6 was this one, it's posted still out there, I think, looking at beryllium markers in induced sputum in dental technicians, dental workers. Well, induced sputum is a very valid way, perhaps, to look at what's going on in the airways, and that was interesting. And finally, fifth, and it's F3, were animal models. And this, again, was sort of, these were beryllium given intratracheally into mice, and then they did BAL. And in the BAL, they found, I love this word, they were looking at cells, they called them nibbling cells. What were the cells that were nibbling at the beryllium particles there? And of course, getting right back to it, the one that was, they had T cells, they had alveolar macrophage, but they had dendritic cells. So again, it flips around to the increased interest, I think, in looking more at dendritic cells. But I love that concept in the alveolus of nibblers who are trying to interact with things. Finally, in terms of training, I'm not going to say anything about that. I was just so pleased to see how dynamically so many the young people, and they were mostly young people, not everybody was young who had a poster, but there were a lot of people, and they were excited about doing the research, and they wanted to have you ask questions, and they wanted to, and I think that bodes well that this would be an exciting way for younger people to be in the future of research. Therefore, I know that a lot of those posters, work that hasn't been published yet, and I think, well, Dr. Boffman, probably Dr. Saltini, people would like for you all to think about submitting those posters and the research in progress to sarcoidosis as a way to have it published. Finally, and I'll just end with this, which was a workshop that I said we were involved in putting together at NIH, and it was published in the Proceedings of the American Thoracic Society, and it came out in 2008, just about the time at the Athens meeting, so really didn't have a chance to talk about it. But it was really, in effect, to challenge people to learn about the rest of the cells that are active in the respiratory tract. And what we did then was to have 4 prominent pathologists, Dr. Terry Franks, Tom Colby, Bill Travis, and Reuben Tudor, to get together and just think. When you're looking at pathology of the lung, you see cells that you don't recognize, you don't know where they come from, you don't know what they're doing. How many of these do you think exist? And they came up with tables, and they've got, they're probably half of the cells in the human respiratory tract that we don't know much about. We actually succeeded in trying to get some, I retired 2 months away from the NIH, so I'm not any longer at the Division of Lung Diseases, so I can talk about maybe. But anyway, we tried to get some research money that would go in to support people that would do infrastructure research. It's not hypothesis-driven research, and it's not that interesting then in some of the things that people want to do, but we need really people who will use the technologies, bronchial lavage, transbronchial biopsy, microdissection, all of these things that you get through the airways to really try to pull out, look for surface markers, make antibodies, be able to separate some of these cells that we don't know about and learn more about them. We really don't know enough about stem cells and some of their origins in the lung, although that's improving. The whole area of neuroendocrine cells is really not looked at. If you're thinking about making a new lung or putting stents in the lung and putting cells on it to repair areas of bronchiectasis and so, those cells are not going to live and do very well unless you know the whole milieu in which these cells live in, and there are probably 42 cells. So that's my perception. I hope in the future that we'll continue to make new observations. We'll continue to work and find out everything about the lungs, including all the cells, and gosh, 3 years from now, hopefully this group will be together again. Thanks.